In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, discuss recent ASC issues and survey experiences, provide an update on fraud and abuse investigations, discuss signage in shared spaces, review rules about transporting medications, and in our focus segment, we discuss patient registration, patient privacy, rights and responsibilities, and posting requirements.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 248 of the ASC Podcast with John Goehle, recorded on June 8th, 2025, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by their relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So I think we say this almost every week, but truly this last week has been loaded with surveys. I think I was involved in 3 surveys.
Yes. Last
week. I almost had 4. And then next week or this coming week, I leave this afternoon. We have 2 surveys. We know we have 1 survey. We're expecting another survey. The organization is actually, their expiration for their deemed status is
Saturday,
next Saturday. So they really have to have the survey this week. So it's going to be a busy week.
Well, hectic for you because you wake up every day and you're not sure where do you have to run off to, to support our clients.
Yeah, we definitely have a lot going on. But, Sue, though, it's been, the surveys have been great. We've had very, very few findings, which is what we like to see, especially with clients that have our full-time retainer service. In other words, we work with them every day. And I just want to remind everybody that as part of our retainer at Ambulatory Healthcare Strategies, we are often there during the surveys. Since we're not considered consultants, consultants really are not allowed to participate in a survey, but we are at Ambulatory Healthcare Strategies and on a retainer contract, we are part of their operations, running committee meetings and working closely with the staff. So I'm very proud of the staff at all those surgery centers. You know who you are, and congratulations on very successful surveys. And Sue, I had a wonderful visit last weekend to Phoenix with LUGPA, L-U-G-P-A, which hopefully resulted in recruiting some new listeners. LUGPA it stands for Large Urology Group Practice Association. And they had a conference in Phoenix where I spoke about ambulatory surgery centers in the urology space. They do this. This was the second year. They're hoping to continue doing it every year.
And you hadn't been before, but you said you really enjoyed it.
I did. The real surprise was I didn't expect to meet a lot of people that I knew. And I walked in and there were just tons of people. I mean, at least half the people, it seems, It's a very small conference, a relatively small group, but I did know quite a number of people, especially the vendors that were working their booth there. And Sue, we have an announcement, don't we?
Mm-hmm. We'll be picking up a puppy to join our Rosie in just a couple of weeks, and we're pretty sure the name's going to be Daisy. I've changed it a couple times, but we do. I think that'll be good. Rosie and Daisy, the whole flower theme.
We're very excited.
Yeah.
It's we keep with Rosie's puppies, as we've talked about a lot on the podcast. Is she's had 23 puppies over the last 4 years, and we have sold them all. So it's nice to actually keep a puppy now. So we're looking forward to it. Though I think we're going to be a little stressed out with the new responsibility we have here. But obviously, we'll keep you fully informed, as I know the audience would like to hear about, and we'll post some pictures on our various websites. So let's talk about some news. On April 28, 2025, the Centers for Medicare and Medicaid Services, which we lovingly call CMS, launch its Fraud Detection Operations Center, or FDOC, because, of course, the government has to put initials to everything. So FDOC, Fraud Detection Operations Center, to address fraud, waste, and abuse in the Medicare and Medicaid systems. There was a report from Fierce Healthcare Reports, and I'll provide a link to it, saying the following. The FDOC leverages the Fraud Prevention System, or the FPS, a system developed, built, and operated by federal contractor Peraton, which uses AI and machine learning to flag fraudulent provider behavior. And in its first month, the FDOC suspended payments to 33 providers, including some outpatient facilities. We don't think any of them were actual ambulatory surgery centers, but some of the issues that they were cited for were upcoding. While ASCs were not exactly named, as we said, they're high-volume procedures. For example, cataracts and endoscopies are prime targets for scrutiny. So a real lesson or a real takeaway here is, there's even more investigation going on and a focus on outpatient surgery or outpatient procedures and surgery in particular. It's really wise for you to make sure you're auditing your billing and coding practices to ensure compliance with the CMS regulations. And I think one thing that I find interesting here, Sue, is especially as we start to embrace artificial intelligence more, is you can imagine how artificial intelligence and machine learning can be really used in looking at and investigating claims processing and coding to be able to find trends. So I think that we're going to see a real uptick in the amount of investigations into fraudulent billing practices. So, I mean, obviously, I think we're speaking to the choir here. It's important that you maintain proper coding and billing practices, use professionals to do your coding and billing, and also always, kind of audit that function periodically by hiring a good company to kind of do periodic audits of your coding and billing functions.
Because I'm sure it's not, I'm sure sometimes it is purposeful, but I bet it's not always. Like you said, if somebody's not very skilled in the particular procedures you're doing and in the ASC space, you could run into problems.
Right. And that really brings up a very important point, is the importance of having certified coders. We talk about this a lot in our presentations and our boot camps, for example, that you really have to use. I mean, it's not a regulation, but you really should be using certified coders, people that really have an expertise specifically in ambulatory surgery coding and billing. And one real indicator for me is when surgery centers use the codes that the doctors use. And in other words, instead of hiring a professional coder to do the coding, they think that the doctor is going to be able to do better coding, and that's really not the case at all. Doctors, have their own expertise. They're doctors, but that's why you have professional coders out there that can code. And another thing that I've always thought too, Sue, is that we're not just looking for situations in where you're upcoding, but there's opportunities to see if you're not billing for all the services that you're actually rendering or for the exact service. In other words, I think just as often as I find there's a problem with them upcoding, we see situations where they've downcoded it, and not on purpose either. And I don't want to say that all the upcoding has been done on purpose like you indicated. Often it's just very innocent mistakes.
And I saw an interesting article in Outpatient Surgery Magazine. This edition was all about construction. So if it's something you're thinking about, it would be a really good resource from AORN. They pointed out a problem that we've seen so many times in new construction. It's so important to hire someone who's experienced in following federal regulations such as NFPA 99, the National Fire Protection Association. And not all architects or builders are familiar with these healthcare requirements. The fire marshal will likely not even be aware that the anticipated levels of anesthesia administered at your facility will affect what is required. So, people feel like they're doing all the right things. They get an architect. They have people who tell them, oh, I've built healthcare places before. Fire marshal does an inspection, and then they, have their survey done by their accreditation agency. And, they find out that there's a problem. And at that point, it's very expensive to fix.
Yeah, you're so right. And this is happening, isn't it true, over and over again. Luckily, often when people bring us into the situation, ambulatory healthcare strategies into the situation before that all critical first survey, we can fix it. But as you said, Sue, it can cost a lot of money to fix a problem if it hasn't been caught by the architect in the beginning. And just because an architect says that they've worked in hospitals or that they've worked in building medical office buildings doesn't mean that they're going to have the expertise to build an ambulatory surgery center. So make sure that you're hiring people that really can demonstrate to you that they've built facilities similar to yours. And then, I know this is kind of self-serving, consider hiring, a life safety expert such as we have at Ambulatory Healthcare Strategies to kind of take a look before you have your first state survey or your federal survey. And another point I want to make too, Sue, is that just because you passed your state survey doesn't mean you're going to pass the CMS survey, because state surveyors have a different focus. And I'll tell you, often the state surveyors kind of say, I'm not going to look at everything because I know the CMS surveyors are going to come in and look at everything else. Yeah. And I see that a lot too, where, people will comment after a deemed status survey, life safety survey, that I don't understand why we have a problem. We passed the state survey with no problem. So again, good point to make, that we need to make sure that we're hiring the right people.
Yeah. And just some news that, kind of on the anesthesia front, that newly certified CRNAs are now going to be required, or now are, and starting at the beginning of this year, are now required to obtain a doctorate degree. So before this year, a CRNA degree included a BSN and a master's degree. Now, this shouldn't be a surprise for anybody who's going to school for this, because it was established in 2009 that the new requirement would become mandatory in 2025. And some programs have started to kind of, move toward that. So CRNA programs also require at least 1 year of critical care nursing experience before acceptance, and many will even require 2 years, which is good. I think it's that experience that I feel like would be so important.
Yeah, we don't want them to rush right into that education until they've gotten some real life experience.
Yeah, you have to kind of have that instinct. Most future CRNAs would likely get their doctorate in nursing practice, the DNP, or nurse anesthesia practice, which is a DNAP. But I was surprised to see that the doctorate degree could also be in philosophy. They could get a PhD, and a few other ones. There's 6 options that they can choose from. But hopefully this is going to lead to more anesthesia providers who can provide care independently. But it's also probably going to discourage some nurses from pursuing this as a career. So, it's that whole, we need more people right now.
Yeah.
This might slow it down, but at the same time, if it allows more people to operate separately, then we may end up with a whole new batch of people that we can count on. And, like we were talking about before, that experience versus the higher level education. I think a doctorate is helpful, but I don't know. I'm not, I'd like to see people getting, a longer internship or something, maybe. I don't know. We'll have to wait and see.
Yeah, I think I agree with you. It's hard to I guess we have to find out how it changes, the CRNA practice.
Yeah.
I'm a big advocate of CRNAs. I think they do a fantastic job generally. And they are definitely helping out in this very difficult time that we have right now with the anesthesia crisis. So.
I think it's kind of state by state what their scope of practice can be. And in the last episode, we were talking about hospitals. I believe it was the last episode, taking more of an interest in working with and investing in ASCs. So the June 2nd Becker's ASC review had examples of how insurance providers are now starting to find ways to encourage patients to have their procedures done in an ASC. Some are allowing certain procedures to be done without prior approval or pre-certification if it's being done in an ASC, whereas they have to apply for pre-approval if they're going to have it done in an HOPD. In New York State, Empire Commercial Plan members now need a medical necessity review to have certain procedures performed in the HOPD setting instead of an ASC. So you almost have to argue not to have it in an ASC if you didn't want it. So they're really recognizing the value and the safety, of course, too.
This is all really good news, I think, for the industry as we try to push more and more cases to the ASC setting. Let's hope it continues.
And an article in Becker's ASC Review with information that they had gathered from HST Pathways State of the Industry report. In a survey of 590 ASCs, they found that smaller ASCs had greater revenue growth than the larger surgery centers. So 2 OR centers had a 22% average growth in revenue from 23 to 24, while larger facilities with 15 or more ORs declined by 8%. They noted this could be due to the flexibility and efficiency of the smaller centers. They also pointed out that a single specialty center can be much more efficient. And they're seeing a trend towards specialization in the ASC market as it matures, and compared this to the tendency of surgeons and other physicians to specialize in one area. Because, boy, you can be really a pro at something if it's just what you do and sort of a well-oiled machine. You know, I saw something else where it compared it to a pit crew kind of a thing. Yeah. Everybody rushes in. They know what to do. They all, work together, know each other. And, that may be the way to really maximize your efficiency and your skill.
Yeah, I find that interesting. When we look at a lot of our new centers going up, I mean, we do have a lot of multi-specialty centers, but truly the single specialty ones really can get up and running very quickly compared to those multi-specialties because they do one thing and they do it very well, as you said. I used to run centers that they were multi-specialty, but they tended to have the same types of procedures, which just to your point, there tend to be smaller surgery centers that are able to be more efficient. So that's an interesting article from our friends over at HST. Let's talk about some of our recent experiences and things that we've noted sometimes during our patron drop-in sessions on Saturday mornings for our patron members, and sometimes just working with our clients. And one thing that's come up, Sue, and in particular this happened actually in New York State, but it's not just New York State, is that several states have introduced legislation that would actually ban ambulatory surgery centers from collecting facility fees. Now, I mean, I know this sounds very strange, and it seems impossible. I mean, why would you ban the sole source of revenue that an ambulatory surgery center has? And it's because that the people that introduce this legislation don't really know how an ambulatory surgery center works. And I'm not trying to criticize them so much as to say that they often, as they introduce this legislation, have a particular goal in mind without realizing the unintended consequences that come out of it. And they often don't do thorough research, or they don't have access to thorough research that shows what the ramifications are. So I don't think there's anybody out there that really wants to put ambulatory surgery centers out of business, but they don't understand by getting rid of the sole source of revenue that we have. Maybe they don't know that that's our sole source of revenue, that it would be quite devastating, not only to the surgery center industry, but to access. If you were to put all those ambulatory surgery centers out of business by taking away their revenue source, there would be a severe access problem throughout our country. Yeah. And
as we saw, the insurance companies are really moving toward wanting, just think of what would happen to healthcare costs if they didn't have ASCs there.
That's absolutely true. And I think that I have not seen any of these situations actually end up passing, but it is obviously something we have to fight. So keep an eye out for any legislation in your state and support your state association as they fight this legislation. So far, as I said, it doesn't appear that anything has been enacted anywhere, but we have to keep fighting it. Or we're obviously going to see some problems. And, it's a good pitch for me to kind of always encourage you to join your state association, not only for that information about legislation and regulations in your state, but also the ability to kind of network with people in similar circumstances throughout your state and nearby. There was also an issue that came up this last week among our clients related to signage for ASCs that share a building with a clinic or an office. So there's actually two ways that you can share space. One is where you have like a clinic or a physician's office that is in the same location as the ambulatory surgery center. We know that the distinct entity regulations require that those two entities to be completely separate. In other words, as you walk in, for example, you go to one direction to enter the waiting room for the surgery center and the other direction to enter the waiting room for the practice. You have to have separate waiting rooms. But there is another option. It's what we call temporal separation. Not temporary, but temporal separation, meaning that you separate the operations by time. An example of this would be where you have the clinic or the office space being an office on Monday, Wednesday, and Fridays, and on Tuesdays and Thursdays, they're a surgery center, as long as you have set times that can be posted on a sign. And that's what it gets down to here when we're talking about the signage, is it really gets complicated when you're doing the temporal separation. As you can imagine, when you're dealing with total separation, you want to make sure that the signage on the outside door as well as the door going directly into the surgery center posts or shows the hours of operations, and obviously has a no emergency services sign. In other words, a sign that indicates that the surgery center doesn't provide emergency services, and if you have a medical emergency, to go to your nearest emergency room. But temporal separation becomes a lot more complicated. So what you'd have to do there is be very specific as to when the clinic and the practice is open, and when the space is in ambulatory surgery centers. And again, post it not only inside where they're entering into the surgery center, but also outside the building so they can see it. And again, always make sure, even if you're sharing that space in a temporal situation, that you have a sign that says that you do not provide emergency services. And if you need some examples, just reach out to me through our email at info@ascpodcast.com. And another thing that came up this last week is a doctor had asked about carrying medication in scrub pockets. So the question was asked, is it okay to carry vials or syringes in their scrubs? And the answer is no. I mean, this has been the case for a long time. Carrying meds in the scrub pocket is an infection control risk, whether it's a vial, a pre-drawn syringe, or any medication. It can get contaminated in your pocket, which could harm patients. Surveyors from CMS or the accrediting bodies will flag this as a violation of safe medication handling. And we want to make sure that your infection control policies ban carrying meds in the pocket. So train your staff on the proper handling of medications, and that if they see a doctor putting the medication in their pocket, they stop it right away and store it appropriately. And, of course, you do want to do regular audits to catch this habit early and keep your ASC survey ready, meaning that you'd include it in your environmental rounds.
So we've been doing a lot of applications lately to prepare for all of these surveys that we have coming up. And there's been some confusion of the time frame that you have to get that in.
And particularly we're talking about HHC here, where once HHC introduced their new application process, they point out in their material that if the application goes in within 60 days or less than 60 days, you're going to have to pay an extra fee. And this has led a number of surgery centers to think that they have to get the application in right around 60 days. That is not the case at all. The actual literature, if you read it deeply, it will say that their expectation is that you get the application in 150 days prior to the expiration of your accreditation. So just something to keep in mind. I know they're not really enforcing this right now, but I do expect them to be enforcing this in the near future.
There's actually quite a few changes, which hopefully in the end it'll all be good. But if you're coming up on having to do this, and a lot of things have changed, so just give yourself plenty of time.
Yeah, very good point, Sue. And again, we're talking about HHC here.
Yes,
we don't have as many of the other types of surveys out there, and I know there are some issues with some of the survey organizations, but I think the transition to HHC has been quite a bit of a challenge. Yeah, right. And I will say that I think the new system is wonderful. It does work well when it works well, and of course, you're always going to go through growing pains whenever you implement something as major as a change as this. But the end result has been a real robust website with a lot of great information that's available to you. Just have to recognize that the first time you do an application with the new system is going to be a bit challenging to you. So we haven't talked about the registration function, patient rights, patient privacy, and anti-discrimination, as well as the posting requirements in the podcast in quite a while. So I thought it might be a good area to revisit. These are key areas for ASCs to stay compliant with the regulatory requirements. So we're going to be back after a short break to dig into the regulations and practical steps to help you be compliant. It's been a long day, and the surveyor has just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So as I said in our segue here, we thought that during this focus segment, we would be diving into a very critical topic, which is the registration function in your surgery center, patient rights and responsibilities, patient privacy, anti-discrimination, and posting requirements. The challenge I think we find is that it's one of those areas that we just assume we know everything about, and we don't keep an eye on it. And Sue, there's always so much turnover in the registration function, the registration people. I always tell this story, but when I was an administrator, there's only two people I would hire. One would be the director of nursing, who would hire everybody else, and the other would be the receptionist. And the reason that I wanted to hire the receptionist is because it was such an important function. It's the first person that everybody saw when they came in. And, you know, they had to have the right personality. They had to be very diligent. They had to be very focused on details. And often they're the lowest paid people in our surgery center. And I tried not to make that the case in all situations, but it's so important and critical that we hire the right people there.
Yeah, this is such an important area for ASC administrators and the nurse managers to be aware of, to ensure patients feel safe and comfortable when they come in. And, you know, it has to be somebody that has that personality, so you feel welcomed when you come in.
Yeah, you don't want a shy person up there, right?
No. And somebody who's, like you said, very diligent, that you will make sure that they're doing everything they need to do to follow all those regulations.
And one point I'll make, too, is that when I was an administrator the second time around, we had Saturday hours, and sometimes we did retina procedures, so we would sometimes have to do procedures on a holiday or, you know, like the day after Thanksgiving. And I wouldn't always be able to get a receptionist to be able to man the front desk. So I learned a lot by being the receptionist that day. And I always made changes, you know, based upon it, because I realized what a tough job they have.
Yeah.
So as always, we want to remind our listeners that they need to understand the regulatory background and what surveyors look for during a survey. Let's start, as we often do when we're talking about regulatory requirements, let's start with the CMS conditions for coverage at CFR 416.50, which is the section on patient rights. And then we're also going to talk about the interpretive guidelines, which set the foundation for today's discussion. Now, I'm going to paraphrase these regulations here. Otherwise, we would be here for a couple hours because there's quite a bit. So we're talking here about 416.50, the condition for coverage for patient rights. And it states this: the ASC must inform the patient or the patient's representative or surrogate of the patient's rights and must protect and promote the exercise of these rights as set forth in this section. The ASC must also post the written notice of patient rights in a place or in places within the ASC likely to be noticed by patients waiting for treatment or by the patient's representative or surrogate, if applicable. So now those are the exact words. I'll just add some comments here. Notice how it says the ASC must post. I don't think it leaves room for interpretation there. You need to post it in a place where the patients coming in and their family members are able to see it.
And Standard A, Notice of Rights. An ASC must, prior to the start of the surgical procedure, Provide the patient's representative, or surrogate with verbal and written notice of the patient's rights in a language and manner that ensures the patient, their representative or surrogate, understands all of the patient's rights as set forth in this section. The ASC's notice of rights must include the address and telephone number of the state agency to which the patients may report complaints, as well as the website for the Office of the Medicare Beneficiary Ombudsman. And you have to double check, and again, those were the exact words, but you do have to keep up on that. Sometimes they change. We've had them change that number, and you just have to be sure you're really up to date with your postings.
Yeah, I think we mentioned in a recent podcast, and somebody actually reached out through our info at ascpodcast.com and asked again for the reference for the ombudsman. So, and again, we'll provide that in the show notes here. So those of you that were listening very closely will note that it said that we have to provide verbal and written notice of the patient's rights. Now, Sue, what do you think that means? Does that mean that the poor receptionist that we've just diligently hired is going to have to spell out the verbally the entire patient rights and responsibilities?
Well, as long as you're handing them the written information, just ask if they have any questions, if they need help understanding it.
That's right. So we've interpreted it as surveyors. That's what we're trained to look for, is that we're not expecting them to actually read out the patient rights and responsibilities, as you might think it implies here, but to ask them if they have any questions about it. However, there is a situation in which you might have to read that out, and that would be where that individual does not speak the language in which the patient rights and responsibilities are written. So let's say that you have a Chinese individual coming in who speaks, Mandarin, for example, and you do not have a Mandarin version of the patient rights and responsibilities, then there would be an expectation that the interpreter would read and interpret the patient rights and responsibilities in the language of the person that is coming in. So that's the one exception I would say there. But to your point, Sue, the best way to handle this, if they are speaking English here, or the language that the interpret, or the language that the receptionist and the patient are speaking, all they have to do is really ask if they have any questions. So moving on, the standard for disclosure of patient financial interest or ownership. The ASC must disclose in accordance with Part 420 of this subchapter, and where applicable, provide a list of the physicians who have a financial interest or ownership in the ASC facility. Disclosure of this information must be in writing. So there's actually two parts to this. One is that if the surgeon for that patient is an owner of the surgery center, you need to make sure that that patient has been informed of that ownership interest. And they're going to have to sign off that they're aware that the doctor owns part of the surgery center. The second part is that if somebody were to ask you to provide a list of all the physicians who have a financial interest or ownership in the ASC, be prepared to provide them that list. So that's usually just something that we keep, like in a drawer and just pull it out if anybody comes in. It's very, very rare when somebody would ask for the names of everybody.
In Standard C, Advanced Directives, the ASC must comply with the following requirements. Provide the patient or, as appropriate, their representative with written information concerning its policies on advanced directives, including a description of the applicable state health and safety laws, and, if requested, official state advanced directive forms. And they must inform the patient or their representative of the patient's right to make informed decisions regarding their care. Document in a prominent part of the patient's current medical record whether or not the individual has executed an advanced directive.
So this is a very important area to keep an eye on. And what we're really looking for here, first of all, we always have to make sure that we tell a patient that they have a right to execute an advanced directive. Where we as a surgery center have a concern is if that advanced directive is a DNR order, a do not resuscitate order, because generally you're going to find your physician and your anesthesiologist do not wish to have the DNR order in place during a surgical event. So if that's the case in your organization, you want to make sure that you inform the patient beforehand that DNR would not be in place. And then to the point at the end there that it has to be documented in the medical record. Make sure there's a space in your medical record indicating whether the patient has executed or has not executed an advanced directive. And it also alludes to the issue of different states. Different states might have their own advanced directive requirements. For example, in New York, there is a requirement that all patients in New York be provided a particular pamphlet or given the opportunity to take a pamphlet that talks about the patient's advanced directives, in particular the healthcare proxy. And moving on to standard F, which is privacy and safety, the ASC must ensure the patient has the right to personal privacy, receive care in a safe setting, and be free from all forms of abuse and harassment. I think that speaks for itself. Standard G talks about the confidentiality of clinical records. The ASC must comply with the department's rules for privacy and security of individually identifiable health information as specified in CFR Parts 160 and 164. And again, I think that's self-explanatory, since I think it would be very rare to find anybody that's not aware of the HIPAA requirements in surgery centers. Mm-hmm. So let's go into a little bit more detail with some guidance provided in the interpreter guidelines. We're looking right now at the 416.50 when it talks about patient rights, or the notice of rights. The written notice of patient rights must be posted in one or more places within the ASC where it's likely to be noticed by patients waiting for treatment or by their representatives or surrogates. So surveyors are going to verify by interview and document review that the ASC provides both verbal and written notice, as we said, of the patient's rights to all patients prior to the date of procedure, meaning prior to actually having the procedure performed. The notice must be provided in a language and manner that ensures that patients, the representatives, or surrogates understand those rights. And it has to include the address and telephone number of the state agency. So you'll want to look up your state regulations to determine the name and address of that department. And of course, as we mentioned earlier, you want to include the reference to the Office of the Medicare Ombudsman. Let's move on to non-discrimination. The ASC must not discriminate against any patient based on any factor, including all those that we know, like race, color, national origin, sex, age, or disability. And ASCs must ensure that patients are informed of their right to be free from such discrimination. So what are surveyors looking for? They're going to look for evidence that the ASC has policies and procedures that address non-discrimination and that the staff are trained on these policies. In addition, surveyors are going to verify that the ASC has taken steps to ensure effective communication with patients who have limited English proficiency or other communication needs, such as providing interpreter services or auxiliary aids. Failure to provide such services may constitute discrimination on the basis of national origin or disability. So you're going to have to pay for an interpreter, and you can't rely upon the patient's family member to provide that interpretation. And the reason for that is you want to make sure that the person doing the interpretation is familiar with medical terminology and isn't going to change the words being said to the patient based upon, something that might happen to family. Like, maybe in some cultures, the interpreter is not going to want to talk about privacy issues or everything that has to do with the health of one of their family members. And then moving on to privacy and confidentiality, the ASC must comply with HIPAA Privacy Act, as we said. And surveyors in this case are going to be verifying that the ASC, again, has policies and procedures with regard to HIPAA, and that the patients are informed about how their health information will be used and protected. And what this means is we're going to have a notice of privacy practices to patients and obtain acknowledgement that they received that notice of privacy practices. So again, this is yet another document that you're going to be providing to the patient upon admission.
So now that we've given you the actual regulations, we want to look specifically at how ASCs should handle the patient registration. John, do you want to walk through that process?
Yeah, so when a patient comes in, again, make sure that your registration clerk is well trained on what to do. But they're going to want to, greet the patient, obviously. Mm-hmm. They're going to have to hand them a series of documents. Let's run through those documents. So first, at registration, you're going to want your registration clerk to make sure that they provide the patient the notice of privacy practice. Now, we all know we've been handed thousands of these documents if we're in regular care of a doctor, but you have to at least provide them with it. If they don't want to take it, that's absolutely all right. And of course, those that are what we call frequent flyers, people that come in frequently in particular, are probably not going to want to take a copy of it, but do provide the opportunity for them to take a copy of the notice of privacy practices. And then a separate document is going to be the patient rights and responsibilities. And again, offer that to them. And while you're offering it to them, ask them if they have any questions, as we said. That way you're going to comply with the requirement that you provide verbal and written notice. Mm-hmm. Next, you want to give them a document that outlines what your advanced directive policy is. And again, here what we're looking for in particular is if they've executed a DNR order, a do not resuscitate order, and at that point the patient's going to have to be informed that the DNR order will not be in place during the procedure. And if they have a healthcare proxy, which appoints an individual to act if they become incapacitated, they're going to want to write that. And again, very important that you write any information about the existence or non-existence of an advance directive in the patient's chart. And then lastly, you want to make sure that they are provided information about the ownership of the surgery center. In particular, if the doctor that is going to perform the procedure is an owner of the surgery center, the patient has to acknowledge that they have been given notice that doctor is an owner. And also, you want to make sure that you have a list of all the physicians that are owners available in case somebody were to ask for it. I did want to point out one other thing. The discrimination poster has to be posted. And this is available from the Department of Health and Human Services website if you want an example of a form. And that just notifies the patients that that they're not going to be discriminated against in your surgery center. Let's just talk kind of briefly about the interpreter services again. What we as surveyors are going to be looking for is, do you have a contract in place or plans for those services? So we're going to ask questions about what would happen if somebody came in and didn't speak English. Quite often you actually are not able as a surveyor to witness the actual provision of sign language, provision of interpreter services. So again, make sure that you can provide a copy of a contract to the surveyors.
Now we want to talk about what should be posted. So what does an ASC need to display?
So I think we've kind of mentioned this before, but let's be specific here. You're going to want to include the notice of the patient rights and responsibilities in a visible area like the waiting room. Now, the Department of Health and Human Services provides a Section 1557 poster stating the patients have the right to fair treatment and free language help. And that's the anti-discrimination poster. Displayed in English and any common languages in your community.
So that'll be, as you said, individual to your community. Really make sure that all of the major areas are covered.
Right. And to that point, Sue, if you hire an interpreter service, I think almost all interpreter services will provide you with a sign that you can put in your waiting area right next to your registration desk that will have the 15 most common languages spoken in your particular community. And again, that's a requirement that you have to have on the desk. That way, if a patient comes in and doesn't speak English, they can point to the language, and you would be able to hire an interpreter to speak that language.
Okay, and lastly, what do the patients have to sign after they receive all of these documents?
So, I mean, typically they sign three things. First is the acknowledgement that they received the notice of privacy practices showing HIPAA compliance. Second, an acknowledgement that they received the disclosure of physician financial interest or ownership, if it's applicable. And third, an acknowledgement that they received the advance directives policy, including any state-specific requirements. They will also sign a consent form for treatment, confirming that they understand their procedures and rights. Some ASCs combine these acknowledgements into one form, but check for your state's requirements. And it's important to note that when we're talking about the consent to treatment, we're not talking about the procedural consent, which is a discussion between the doctor and the patient. We're talking about the notice or the consent for treatment, which allows the patient to be treated by your staff, like the nurses in your organization, for example. And I found that recently, Sue, that sometimes organizations have never had a consent to treatment, or when they converted from paper to the electronic version. This in particular has happened quite a bit in the last couple of weeks, where they have forgotten to include the consent to treatment in the documentation that they sign electronically. So common mistakes, that we find in the registration function, really probably the most common one is rushing registration, not explaining the documents or lacking interpreter services. Using untrained staff as interpreters is a real compliance risk, so make sure that you avoid that at all costs. And also verify that your posters are current and visible to avoid any survey issues.
So I think the key takeaway from all of this is review your policies, train your staff, and keep those posters updated. And we'll provide links to CMS and HHS resources, and keep listening. We're always updating when we hear of new things.
That's right. We promise. I think it has been almost 4 years since we've talked about this, maybe even a little bit longer. So we'll try to do this a little more frequently. So let's take a short break, and when we come back, we'll talk about upcoming events.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So the Gulf States Conference, which is Alabama, Louisiana, and Mississippi, is going to be June 11th through the 13th, 2025 at the Ritz-Carlton in New Orleans.
The Texas Ambulatory Surgery Center Society Conference is June 23rd through the 25th at the Omni Las Colinas Hotel in Irving, Texas. And John, you're going to be there?
I will be. We're going to have a booth. I don't think I'm speaking there this year, but we'll try to do a podcast from there. And, of course, make sure you stop by our booth so you can talk to us. And the Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 23rd through the 25th at the Hilton Orlando.
And the California ASC Association's conference is September 3rd through the 5th at the Sheraton San Diego Resort in San Diego, California.
And I'm very excited about this year. We're actually going to be doing a cask review class there, which is a kind of a first. And I believe, well, I don't believe, I know that they're going to be doing a cask test there. Like usually people take the cask exam electronically, but CASA has decided that they're going to offer the opportunity to do a paper version of it. So we'll see how that goes, and hopefully I'll see you there. And the Atlantic States ASC Conference and Trade Show is October 2nd and 3rd at the Embassy Suites by Hilton in Raleigh-Durham Research Triangle in Cary, North Carolina.
And the New York State ASC Association's conference will be held October 6th through the 8th at the Desmond in Albany, New York. And John will be speaking at the conference, and we'll do a special episode, and there will be quite a lot of the group from AHS.
Yes, and the other thing is we're going to be actually sponsoring the entire day beforehand, which is going to be a pre-conference. I think we're hoping to get about 7 credit hours. So if you're from New York State or neighboring states, feel free to sign up and attend the conference. And the Oregon ASC Association's annual conference will be October 9th and 10th. And I will be speaking at the conference, and we'll do a special episode from there also.
The Joint Commission's Ambulatory Care Conference is November 5th and 6th, 2025 at the Crowne Plaza, Chicago O'Hare in Rosemont, Illinois.
And the WASCA, or the Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th at the Tulalip Resort and Spa in Tulalip, Washington. And I'll be speaking at the conference, and we're also going to be doing a special episode from there.
And the Colorado ASC Association's conference will be November 13th and 14th at the Denver Marriott West in Golden, Colorado. John will be speaking at the conference, and we'll do a special episode.
Absolutely.
A lot of special episodes coming up.
We're
usually get really good content out of it.
Yeah, we're going to be very busy. And I love being in Golden, Colorado, because, of course, we have a Golden Retriever, and they hold a very special Golden Retriever conference, or what do they call it, the event there every year. Don't forget, on-demand versions of the ASC Director of Nursing, Administrators, and Business Office Managers boot camps, there's 3 different boot camps there, are available on our sister website at asc-central.com. And just a reminder to everyone to become a patron member of the podcast. Don't miss out on the benefits of joining our patron member program available at asc-central.com. This comprehensive membership platform for $25 a month is your go-to resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management. And it's really designed with busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to regular drop-in Zoom sessions, as we call them, which are typically held weekly. This last week, it was on Friday. Sometimes it's on Saturdays, and sometimes it's on Mondays. We always give you a heads up before the actual meeting so that you can join us from wherever you are. But that's really just the beginning. Your membership unlocks a wide range of resources, including access to various virtual conferences, such as our credentialing conference and the Conditions for Coverage conference. And you also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. And your support through the patron program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, please visit asc-central.com. Thank you for tuning into this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community, and be sure to subscribe so that you never miss an episode. We appreciate your feedback and suggestions for future topics. Feel free to reach out anytime at comments@ascpodcast.com.
A special thank you goes out to our incredible team, sound editor Susan Cronkite, executive producer John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Caloritis, Jim Masters, Amy Cronkite, Lori Rodricks, Kathy Fody, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.